Anaphylaxis is a severe hypersensitivity reaction caused by the degranulation of sensitized mast cells and basophils after exposure to an antigen. Mast cells are located in the perivascular spaces of the skin, lung, and intestine, while basophils are located in the blood. Upon initial exposure to an antigen, immunoglobulin E is produced and binds to the surface of the effector cell. With subsequent exposure, the antigen binds to the IgE antibodies releasing physiologically active mediators that include histamine, tryptase, chemotactic factors, and platelet activating factor. Furthermore, metabolites such as prostaglandins, kinins, leukotrienes, and cytokines are synthesized and released. Histamine is a primary inflammatory mediator which is stored in granules within the mast cells and basophils. Histamine has an important role in the clinical signs and symptoms manifested in anaphylaxis and works on receptors to cause vasodilation, increased vascular permeability, contraction of most smooth muscle, other than blood vessels, cardiac stimulation, and stimulation of gastric secretions. This results in a series of potentially life-threatening symptoms occurring most notably in the respiratory, cardiovascular, and integumentary systems. It is possible for an anaphylactic reaction to occur on first exposure to anesthetic medications due to cross-reactivity among many drugs and commercial household products. The time of onset and the degree of clinical manifestations can vary greatly, making diagnosis complicated. In addition, many symptoms may be masked by general anesthesia and the use of surgical drapes which conceal the cutaneous signs. The most common triggering agents for an anaphylactic reaction during anesthesia are neuromuscular blocking agents. They account for more than 50% of the total incidence. Other causative agents include latex, antibiotics, colloids, hypnotics, contrast media, protamine, and opioids. There are also several other medications, medication classes, and substances that have the potential to trigger anaphylaxis. The signs and symptoms of an anaphylactic reaction are the consequence of the antigen-antibody reaction and the body's massive immune response that includes the release of histamine. As a result, pruritus, urticaria, angioedema, especially laryngeal edema, hypotension, tachycardia, dysrhythmias, wheezing, and bronchospasm may occur. A shock-like state can develop that is secondary to severe hypotension caused by vasodilation and the extravasation of protein and fluids out of the vascular compartment. The clinical appearance of anaphylaxis may present in various combinations and usually occurs within minutes of exposure to the offending antigen. However, in some cases, the onset of signs and symptoms may be delayed for an hour or longer. Tryptase is an enzyme released from mast cells, along with histamine, and has a half-life of several hours. It has been shown to be a positive indicator for an immunologically mediated event at levels greater than 25 micrograms per liter. However, the presence of normal tryptase levels should not rule out an anaphylactic reaction, since normal levels have been found in up to 1/3 of anaphylactic cases. Anaphylactic reactions are life-threatening and require prompt identification and immediate treatment. Treatment includes calling for help, removing potential causative agents, increasing FiO2 to 100%, administering epinephrine, establishing a secure airway and ensuring adequate IV access, providing a fluid bolus. If there's no response to these interventions, an epinephrine infusion should be considered. Other treatment options to consider include vasopressors, beta-2 agonists, histamine blockers, and steroids. Airway patency must be accomplished by means of intubation and maintained, since edema in the airway is a common complication of anaphylaxis. Epinephrine should not be delayed due to its positive hemodynamic effects, as well as its ability to stabilize mast cells and reduce the amount of inflammatory mediator release. Epinephrine can be administered intravenously or subcutaneously and the dose should be titrated according to the severity of symptoms. Antihistamines may be useful, particularly for symptoms of urticaria and angioedema. H1 and H2 receptor antagonists are frequently administered to counteract the effects of histamine and may assist in reversing hypotension refractory to epinephrine and intravascular fluid replacement. Glucocorticoids may reduce the risk of recurring or prolonged anaphylaxis.